So hello friends, welcome to yet another session of Dr. Sahasranam's ECG quiz. I hope you have revised your previous sessions on my ECG classes and are taking full advantage of these quiz sessions. Today I will be discussing two arrhythmias and one 12-lead ECG with you. I presume that you are ready with your pen and paper to interpret the ECGs. So let us get on to the ECGs. Now this is the ECG of a 55-year-old gentleman who had been admitted to the hospital multiple times with history of chest pain. Now this visit he came to the emergency with a feeling of palpitations and giddiness of sudden onset since morning. So my questions here are two. One, what is the diagnosis in this 12-lead ECG? And second, what is the irregularity in the ECG which you see? The irregularity seen here, what is it due to? So you can start off. I'll give you about 2.5 to 3 minutes for the discussion, before the discussion. So I'm sure you are ready with the diagnosis here. We'll go on to the discussion now. Now this 12-lead ECG here shows, important thing is look at the whole ECG and you don't see any P waves, right? What you see is just a fluctuation of the baseline, that is due to atrial fibrillation, right? Now the QRS also, if you look carefully, the QRS, it is widened and it is 4 millimeters in width, that is 160 milliseconds. Now lead 2, lead 3 and lead AVF, they show Q waves but without an ST elevation or without a T abnormality. So this indicates an old inferior wall myocardial infarction. It is an old infarction, not a fresh infarction. Now if you look at leads V1, V2, V3 and even V4, what you see is a QR pattern, isn't it? It's better seen here, QR pattern, which and ST is elevated, right? Significant ST elevation is there, especially in V3 to V6, right? And it is also showing a code upper part. The ST is code. So this indicates an acute anterior wall myocardial infarction. Now this QR will indicate a right bundle branch block. So the full diagnosis here is acute anterior wall myocardial infarction with a right bundle branch block, which because of the QR pattern, right? And looking carefully at the bottom strip, you know that the patient is having an atrial fibrillation because the rhythm strip is totally irregular. The P waves are absent, isn't it? So our full diagnosis in this patient will be old inferior wall infarction, acute anterior wall myocardial infarction with the right bundle branch block, and atrial fibrillation. I am sure most of you would have got this correct. Now we will go on to the second ECG. Now this is the ECG taken from a female. She was 33 years old and came to the hospital with palpitations, and she has been on treatment for heart failure. That is known. Now the cause of heart failure I will ask you later. You will have to answer that. Her symptoms are of many months duration, and she was on treatment for heart failure, which I have already said. My questions here are, what is the arrhythmia? What could be the underlying disease of the patient? What is the disease due to which she has been in heart failure and treatment? And third thing, what could be the cause of this particular arrhythmia which you are seeing here? This has a specific cause. What is that? So you can start answering this. I'll give you about 3 minutes for this also, because I know this is a little tricky. So friends, we'll go on to the discussion of this ECG. Now, as I already said, this is a rhythm strip of a monitor lead. The reason why I have specified monitor lead is when there is a monitor lead, don't bother about the tall R waves or the deep Q waves or S waves or whatever, because this is in the monitor, in the cardiac monitor at the bedside of the patient. So the attendant could have increased or decreased the height of these QRS complexes just to get a good picture. So don't bother about diagnosing right or left ventricular hypertrophies, etc. from a monitor lead. That you should remember. Now, the most important things are there are no P waves seen at all, isn't it? The baseline here shows very coarse waves, which classically indicate again what? Atrial fibrillation. So this patient also has atrial fibrillations. But you see that the QRS complexes are narrow and are very regular. The QRS complexes are coming regularly at a rate of 100 per minute, because this is 300. I'm sorry, yeah, this 3 large divisions, that is, so 300 divided by 3 is 100, right? So what is this arrhythmia? It is a atrial fibrillation. That is obvious. Now the second part of the question. Why is this QRS not irregular? It is regular, no? In atrial fibrillation, we always expect a totally irregular QRS complex. Here it is regular. Why? Because the patient is having an atrioventricular dissociation. The atrial fibrillation is not being conducted down across the AV node into the ventricles. It is dissociated, and the ventricles are run by a different rhythm which is regular. Okay, so that is why you are having a regular ventricular rhythm. So the question comes is, what is this ventricular rhythm? It is a narrow rhythm, it is a regular rhythm, and is occurring at a rate of 100 per minute and is not controlled from above. So it is an accelerated junctional rhythm, right? So this is accelerated junctional rhythm with atrial fibrillation. Now the next part of my question was, what do you think is the underlying disease in this patient? Now if you look carefully, the fibrillary waves are very coarse. You can see, isn't it? They are very coarse fibrillary waves, and the fluctuations are more than 1 millimeter in amplitude. When it is so, you call it a coarse atrial fibrillation. And the classical condition where you get coarse atrial fibrillation is when the atria, right and left or either of the atria, are enlarged. And classically in this patient it was due to rheumatic valvular heart disease, for which he was on treatment in this hospital. Also, I said that this patient was in heart failure. The heart failure could have been due to the rheumatic valvular heart disease. It can also be due to a disease like, say, cardiomyopathy. A dilated cardiomyopathy also can present just like this in a 32-year-old lady. Now the third part of my question was, what was the cause of this particular arrhythmia? Or I said abnormality, it is this arrhythmia. So what caused this arrhythmia? Now if you look carefully, AV dissociation with accelerated junctional rhythm can occur in digoxin toxicity. This lady was on treatment for long-term treatment for heart failure. Naturally, she would have got digoxin. These ECGs are about 30-40 years old. And so at that time, we were regularly giving digoxin to this patient. And digoxin is given also in atrial fibrillation to control the ventricular rate. But the patient can go into toxicity, and one of the arrhythmias which digoxin toxicity produces is AV dissociation with accelerated junctional rhythm. So that is what this patient had. I am sure you would have at least partly diagnosed, and if somebody has diagnosed all these things in this, I think he deserves a 100% mark. Good. Now we'll go on to the next ECG. So it was atrial fibrillation, AV dissociation with accelerated junctional rhythm, cause being digoxin toxicity. Now this is an interesting ECG. You should look at it very carefully. This was the ECG sent to me by Dr. Hari Krishna, who was working with me in Baby Memorial Hospital. It was the ECG of a 60-year-old gentleman who was on treatment for coronary artery disease for the past 2 years. Now, my question is, what do you see in the ECG? That means, what is your diagnosis? Simple. Only one question. Now, if you tell me the diagnosis, you will have to substantiate the diagnosis with specific points. Now, here I want to give you one clue. Don't look at 1 or 2 leads and make a diagnosis. Look at all the 12 leads in this ECG, because there are certain findings in certain leads which will give you clues, which you may miss if you don't look at all the leads. So you can start off answering this. I'll give you 3 minutes for this also, because I know it's a little difficult one and there are multiple findings to be picked up. So friends, I gave you a little extra time. I'm sure you would have made a diagnosis, isn't it? Anyhow, we'll go on to the discussion of this ECG. Now this discussion of the ECG is going to take a little longer time than most of my other discussions. So we'll start off here. Now this is a 12-lead ECG showing a wide QRS tachycardia with uniform complexes within each lead. That means in one lead you are seeing all the complexes are uniform, isn't it? There are no different morphologies of the complexes. Now the QRS complex is 3.5 millimeter wide. I have measured it for you. So that is 140 milliseconds. The duration of QRS is 140 milliseconds. And the rate of QRS, which I have calculated. Now between two R waves, the distance is 9 millimeters. And I calculated it 1500 by 9, which works out to 166 beats per minute. 166. So it is a fast, regular, broad QRS tachycardia. So for practical purposes, the first diagnosis is always ventricular tachycardia. And if you have made a diagnosis of ventricular tachycardia, you are correct. But then, what are the points? I told you must give me what are the criteria or points by which you made this diagnosis. Right? There are certain specific points which I have discussed in my previous classes. So I will first outline the criteria in one slide, and then we'll come back to this slide again and discuss. So now here, The following are the criteria for the diagnosis of ventricular tachycardia. Very broad complexes of 160 millisecond or more. In this patient, do you have it? No, I said 140 milliseconds, isn't it? Absence of a typical RBB or LBB morphology, right? Now in this also, that is present. I will show you again. Extreme axis deviation, which is called northwest axis. Northwest axis means axis pointing towards the right shoulder. That means AVR should be strongly positive. AVR is positive because the axis is like this. Okay. The other thing is AV dissociation. You should show evidence of atrioventricular dissociation. That is, the P is coming at a different rate or a slower rate. QRS is coming at a faster rate. So that you should show. Now, positive or negative concordance throughout the chest leads. So if you take chest leads V1 to V6, either all of them should be positive or all of them should be negative. The presence of capture beats, which are sinus beats, or fusion beats, which are a fusion of sinus beat plus the ventricular complex. Notching near the nadir of the S wave. This is seen in precordial leads, which is known as Josephson's sign. I'll come to it again. The interval from the onset of QRS to the nadir of S wave, that is more than 100 milliseconds. That is called Brugada sign. From the onset of QRS, beginning of the QRS to the nadir of the S wave. And the last is RSR complexes with a taller left rabbit ear. So these are the criteria which we should take into consideration. Again, looking at, we'll go back to the ECG and look at it again with all these things in mind. So now my question is, what are the points here which will tell you that this is a ventricular tachycardia, isn't it? One is you have uniform complexes in a particular lead. You take any lead, all the complexes are uniform. That is one point. Even though they are not 160 milliseconds, around 140 milliseconds wide, right? Second, if you look at the QRS complex, it doesn't look like an RBB and it doesn't look like an LBB either. V5, V6 doesn't show LBB pattern and V1 doesn't show RBB pattern. So it is neither of these two. Now, if you look carefully, lead 1 is positive and lead 3 is negative, isn't it? 1 is positive and 3 is negative. So what is the axis? The axis is a left axis deviation. Now, if you look carefully again, lead 2 is negative, right? And if you invert AVR, it will be positive. So the transition should be between lead 2, which is 60 degrees, and inverted AVR, which is 30 degrees. So it is, the transition is at 45 degrees. Hence, adding 90 to this, the QRS axis is 45 degrees. Do you agree? Right. Now we'll go down. There are one more point. If you look at the precordial leads, I said concordance. That is all the QRS complex having either positive or negative. That is called concordance. That is also not present in this ECG. Is there fusion complex in this ECG? No, there are no fusion complexes. Are there capture beats, that is occasional sinus beats? There are no occasional sinus beats. So these are points which tell you that this may not be VT. But see, when you have multiple criteria, you don't have to have all the criteria in every patient to diagnose VT. So some of the criteria are enough. Fusion beat is an important criteria which is diagnostic, right? But here we don't have it. Another diagnostic is occasional capture beats. Then definitely it tells you. The concordant pattern and all may be there, may not be there. Okay. But there is another very important thing. That is also a diagnostic criteria. If you find AV dissociation, that is P waves coming at a different rate and QRS coming at a different rate. I have showed you in the previous slide. In this patient, we have AV dissociation. You can see these are the P waves. Those red arrows show the P waves. And if you look carefully, those P waves are a little peaked compared to the next two T waves. So this is actually P is falling on the T. That is why you get a slight peak. If you enlarge it, you will see it better. Okay. So there is a P wave dissociation. The P wave is at a rate of around 75 only. Okay, whereas the QRS is very fast. I told you 166 per minute. So AV dissociation is definitely there, which is also a diagnostic point in VT. So you have enough points in this patient to see VT. Now that Josephson's and Brugada's criteria, that you have to see in an enlarged picture, which I will show you in the next slide. Now here, look at this. That is, this is a notch present at the nadir of the S wave, isn't it? That is called Brugada's sign. A notch at the nadir, right? That is called Brugada's sign. That is present in this patient. The other thing, the duration from the beginning of the QRS to the nadir of the S wave. Here also, beginning of QRS to nadir of the S wave. The arrows are showing that is 3 millimeter here. 3 millimeter is 120 milliseconds, right, in this patient. If it is more than 100 milliseconds, you call it Josephson's sign, and that is a point in favor of ventricular tachycardia. So you have two more findings here in favor of ventricular tachycardia, the Brugada sign and the Josephson's sign. Now let us look at the ECG, whole ECG once more. Right? Now what is this? If you look carefully, I have taken another lead here. You can see that is a peak. This is the left rabbit ear is taller than the right rabbit ear. That is another point which favors ventricular tachycardia, right? So you have 4 or 5 points here which favor ventricular tachycardia, right? So you see multiple criteria. Is there anything more? Again. So folks, I hope you have enjoyed today's quiz session. Don't forget to revise the criteria for diagnosis of ventricular tachycardia. Very important, right? Meanwhile, you may put your comments or queries in the box below and share this with your friends and colleagues. And if you have not done so, please subscribe to my channel. I will meet you again with another session of ECG soon. Till then, goodbye.